whatever you're looking at. You can use these glasses, or you can look at the screen, or you can look at the microscope. But you can always insert augmented reality into your visualization. I use the microscope, and I want to show you a MIST lift where we use, and the microscope is navigated. You can see the reference array here. So we're doing MIST lift procedure here. And I mentioned before that MIST lift is a totally standardized procedure. You always look at the same anatomical landmarks, but they can be hard to find if somebody has severe arthritis. Finding the intracranial of the lamina, the pars, the facet joint can be quite difficult because of the individual changes, but the landmarks always remain the same. So what we do is that we identify the bony landmarks on the intraoperative CT scan, and we mark them in different colors, and then project them into the visualization. And under the microscope, then when we drill, we can see the pars, we can see the lamina. In this case, we can also see the pedicle screws that were already placed as the first part of the operation. And then we use those, my fellow marks the pedicles here in different colors, the lamina, the pars, the disc space, the facet joint. And when I come in, I bring in the microscope, I place the tubular retractor, and now I can see the inferior edge of the lamina here, the disc space, the pedicle above, the pedicle below, and this is the pars. We still have to figure out exactly what colors to use so you can really see it very, very clearly. We're kind of playing around with different colors, which is quite interesting also. And so we're trying to get to the point where you basically bring in the microscope and you see all the relevant anatomy immediately, or at least you kind of know where it is. And then you obviously still have to drill bone, you have to remove osteophytes and so forth to get there. So this from the right side, and this little red dot here marks the inferior edge of the L4 lamina, and this is the pars. So I know that I have to connect those two dots in order to disconnect the interarticulating process of L4. And this is the facet joint that was marked. So we're playing around with this right now. We've done about 10 cases, but it's an attempt to kind of take advantage of technology. And I think that once we get really fast, and right now it takes maybe 10, 15 minutes out of your case because you have to pause every once in a while when they're marking things. But once you really get this figured out, I think this can be very, very helpful, at least for training and teaching purposes, you know. So this is now, this ligamented flavor, we disconnected this. This is the facet joint that we're mobilizing now. We made that cut from the lamina to the pars. And now we're looking at the L5 pedicle here. And now we're, the disc space is underneath here. And then now we're projecting the disc space into the picture and so forth. So it goes on and on. But we've got, so that's one way of using augmented reality. Obviously, other surgeons use it with goggles to put in the pedicle screws, which is also great. I was always more interested in microsurgery, so I kind of thought that this would be helpful. I'm not going to go too much into this. I use it for ACDF surgery as well, but I'm running out of time, so I just want to basically reiterate that I think the most important thing, especially for young surgeons to understand, is if you really want to become a successful spine surgeon, you got to understand that technology is your friend. Don't let the companies or others tell you that robotic is different from navigation. You got to look at it as the whole package. So there's robotics, there's augmented reality, virtual reality. If you really, really want to take advantage of the technology, you got to look at it as a whole. You got to figure out what are the pros and cons for individual pieces here in your surgery. And I think that the concept of total navigation is really interesting. That we can totally eliminate fluoroscopy. Robotics is great because it kind of gets you used to the concept of planning things and automation, and then augmented reality, see-through technology. So those are the kind of like the three areas that I find really interesting. And again, thanks for your attention. And I'm very excited to be part of this.
Thank you so much, Roger. It was a really amazing presentation. This is how I always known Roger Hartel. I met him first in 2013 in Austria. And since then, I know him always being on top of the technology riding the wave. So really, really good presentation. Thank you so much. I hope this was interesting for the rest of the presentations. The rest of the participants of the webinar, and I really would like to point your attention. Be very careful. This is for the juniors, because at the end of the webinar, I'm going to ask you one question, and you will have to give me the correct answer. And then, if you give me the correct answer, I will have a surprise for you. So now we can continue probably with Mike. Mike, do you want to present Professor Butler?
Absolutely. Thank you. Thank you, Nikolai. So it's my honor to introduce Professor Joseph Butler, Joe Butler. He is a consultant orthopedic spine surgeon who does both academic teaching spine surgery as well as complex spine surgery. He trained at the Royal National Orthopedic Hospital in the UK, but also spent time in training at Beth Israel in Boston and the Rothman Institute in Philadelphia. He's a full-time consultant at the National Spinal Injuries Unit. And I think, is it Mater University Hospital or Mater Private Hospital in Dublin, Ireland? He's been there now for over 3 years. And what's interesting about Dr. Butler, what we're going to hear about, is he set up the first robotic spine surgery program in the UK in Ireland at the Mater Private Hospital. So it's going to be very interesting to hear about his sort of experience. He's going to talk to us about setting up a robotic spine surgery program in your hospital. He's the clinical lead for robotic spine surgery at the NSIU, and they're about to launch, and maybe they already have, the first robotic spinal navigation program in UK and Ireland to include both navigated microsurgery and augmented reality platforms. He's also the secretary of the Irish Spine Society and a member of the Robotics Navigation Committee of NAS. He's a prolific academician. He's published over 120 articles and 26 book chapters in one book in the field of neurosurgery, including over 155 scientific presentations, and is funded with over 3 million euros in research funding to date. So, Professor Butler, it's an honor to have you here on this webinar. We're very interested to hear about setting up a robotic program in our hospitals.
Thank you very much, Michael. So, pass the screen to me. Let's do that.
Yeah, you can share, Julia. We don't see you as yet.
Wait.
There should be a green screen. There's a share screen green button at the bottom of your screen. It's just, if you just press that, and you will possibly see the screen.
Nikolai, we don't have to allow him to share. It should just be automatic, right?
Yes, yes, yes. It should be automatic. Yeah.
Hey, Omar. How you doing?
How are you?
Good. I'm getting ready for the artificial intelligence. We talk later. Okay, after the conference. Okay, we talk. I call you. Okay. I gotta go. Okay.
The first one is starting very soon.
Okay.
This is part of the initiative of the World Spinal Society of increasing the knowledge of our members, and you can see on screen now the benefits that these webinars will be. You will have the following benefits when you attend these webinars and when you subscribe for these courses. We have decided to keep these courses for our members, but it is very easy for you to become a member of the society if you're interested. We have high quality teachers that we managed to gather for you, and you can see that it's going to be really beneficial for you to be part of this program. At the end of the program, you will have certificates which will certify your attendance and your achievements. So I really urge you to consider strongly and to be part of that. And remember, I told you that there will be a surprise for one of you, one of the juniors at the end of this session. So be careful and just be mindful of the presentations. Joe, you're ready to go?
I'm struggling a little bit to the screen share won't seem to share with me.
Maybe, so now you must share, then Professor Butler will be possible. Do you want to try now?
Okay. Doesn't seem to let me.
Normally, it's very easy to do. Find this green button that is share screen at the bottom.
Yeah.
So you can click on that. You said you can click on the green share screen button. Then there is an option share screen. So you can click on that screen as well as the presentation window.
We'll share screen.
Is your presentation?
You said you can click on the green.
Hello, Cyprian.
Hello. Hi. How are you?
How you doing?
Pretty good. Just arranging a few more, like some problems into the slide in here, but
Yeah, no
other
problem.
than
We have lots of time.
I'm good to go. It's going to be a little bit shorter than the ones before.
That's fine. Have you now you've heard from Mike Cherian, right? Have you heard from anybody else?
Yes. I did hear from Ike Cherian, and I heard from let's see. I talked to
Ben really wants to hear from you from China.
Yeah, I didn't. Yeah, I didn't talk yet with Ben and Borba,
Okay.
but I talked to the guys in
Cyprian.
yeah.
Ben is probably the best guy in the world
Mhm.
to align with as far as neurosurgery. A leading neurosurgeon in China. Tell me about it.
Yeah, the only issue is that the things from regulatory people from the government and stuff,
Right.
they are still active in terms of collaborations with the AI. So
that I don't know, but I would think that China would be less regulatory.
not regulatory, like our people don't allow the collaborations to go on in terms of the AI. So
okay.
I hope they are being lifted as soon as possible, because this
Well,
is really
I guess look into it.
Yeah.
Start the ball rolling, because you know what's going to happen eventually.
Yeah. I don't know. It was like the dark ages of science for a little bit there.
Yeah, I think the laws have to adapt. They can't stay the same.
Yeah. So today I'm just going to go over kind of like guiding the aneurysms treatment, but this can be applied to a lot of other stuff. So
Okay.
and the software that I'm going to show at the end, a few snapshots, actually I can turn it into a product anytime that someone wants to use it. So
Okay.
yeah, so it is we're moving towards that direction. but the data set that we're training, it is far from being acceptable. So it has to be multi-center, multinational. It has to be across a few countries. Yeah. Mhm.
Well, you know, if I could get a kind of a sheet of what you are looking for in a collaborator. Do you know what I mean? Your A,
Yeah.
B, C,
So
and I could
at the
spread it
end,
around.
it is for us to be able to collaborate and be willing to work to overcome the IRBs because it's not only us but everyone else has really this very strict rules about sharing data and patient information, which
Oh,
is
okay.
not actually, it's not, we're not sharing any identified
Nothing
patient
personal.
personal. We just need the
Right,
pictures and we don't want to know what happened to this patient. So
right,
at the end of
right.
the day, but we talked to the people in Turkey, in Ankara, and my goodness, they're adopting the European Union rules about the patient confidentiality and stuff, and they're saying that it is like it has become ridiculous for them also to get approvals and work with this things. I would say now, if we start a study and we need to have access for the data to publish and work, the IRB process and approval is a couple of months. And then equivalently, the study will take the same amount of time. So
Well, yeah, yeah, confidentiality,
yeah,
archaic. They're
yeah,
archaic laws.
we're a little bit lucky because we are in a hospital. So as long as we don't publish and we do not do we do not use it for research reports or anything public, we can still look at the patients,
Okay.
and even for quality assurance and so. But working outside, it's becoming an issue
Okay.
across the world. We talk to people in Ireland, we talk to people in France, and they are facing exactly the same issue.
Well, you know, one thing I want to say to you, Cyprian, is that you've come to the right spot if you want to get
Yeah.
some neurosurgeons.
Yeah.
Because
I'm noticing.
Hyperion, he knows everybody in the world.
Mhm.
And because it's not a big community, it's like 60,000, 55,000 in the world. And the people at the top, they see the same people at the conference. You know how it is.
Yeah,
It's
yeah.
the same people. And so they know each other. So I don't know if you're going to work with Ip as a data center, but he could connect you to almost anybody.
Yeah, I
that
will.
you
I
want.
will. I've seen some emails this week. This week I wasn't able to network as much as I wanted, but once this presentation is done, I'm going to get at it.
Yeah, anything you want in the future, let us know. We can do it. We have access.
Well, I talked to Miri, and he wants to have his sign conference in image guided neurointerventions.
Oh, wow. He'd like to give a presentation?
He wants to have it in person in England, from what I understand.
Oh, okay.
This year in
okay.
September, October. So I exchanged a few emails with him, and hopefully we'll get back to meeting in person, because I have to say it. There is a little bit of a Zoom tiredness.
Yeah. Oh, I've seen that because I
So
spend all my time on the computer.
yeah.
Initially, there was a burst, and
Yeah.
I thought, wow, there's going to be so many people wanting to have their webcast televised. But no, it went way down. You know, like you say, fatigue after 1 or 2 months, people really get tired of it. Most people, I love it, but you know, most people don't use it like I do.
No, I have a year now. You know, we went into quarantine on March 15th.
Okay.
All classes, everything went on Zoom like overnight. So it's enough. We all got vaccinated at work, so the lab was like
That's a
back
relief.
full.
That's
Yeah.
a relief. Getting vaccinated, I immediately felt relief after I got that second one. I said, well, now I don't have to worry so much. But because in
I'm
the
waiting
back of your mind, this disease, Cyprian, it knocks off people at random. Sometimes someone that's relatively healthy, it'll knock them off. It was so
Yeah.
strange.
Yeah.
And
I know.
physicians, because we obviously keep in touch with physicians around the world, neurosurgeons, and neurosurgeons that were not old were dying in Mexico and places like that. They have a bunch of doctors that have died that don't have any risk factors, are good in good health, but they contracted it.
I know someone in the VA hospital the same way, healthy person and so, but then he passed through it, but then he started to have a cardiac arrhythmia. Otherwise, very healthy person and active, and after the COVID finished, he started having like these problems, ending like
Really?
every second or third week back into the emergency room with cardiac arrhythmia, which is very
Wow.
strange.
Yeah, he's going to have a pacemaker put in.
Mhm.
Probably been offered to him.
I'm going to go really quickly, grab a
go ahead,
coffee
go ahead.
refill,
Go ahead.
and
Go ahead.
I need like
We have 13 minutes.
Okay. I'm back. So
Okay.
John, I'm going to go over. I don't know, like really in the beginning, I have like two basic slides and stuff, but how, on your experience, how many people do pipeline treatments and and boils from this audience?
I would say a high percentage, but I would say because it's mostly residents and there are some med students, but it's mostly residents, I think, around the
Okay,
world.
so
Mostly residents.
then I'll go and I'll discuss it.
But there are a lot of neurosurgeons that want to know about AI, like Dr. Ben. I mean, there's a lot of neurosurgeons that want to learn it, and they heard about it. I mean, someone like Ben, who was a very smart guy, obviously head of a department of one of the biggest hospitals in China, said it's the future of neurosurgery. He said that. I mean, he has been around. I mean, and he's authoritative.
Yeah.
So he knows that it's a direction, according to him, and he's a very smart man.
Yeah.
And most neurosurgeons like me, we just don't know that much about it. How it could impact, what can it do, how can it apply, to operating and stuff like that. Yeah, I said he'd come,
Mm.
but no, that last show was a home run audience. Borba, I mean, Borba he's the head of Flan, and he's uh, they may not want to, but they know they have to keep keep tabs on what's going on. And if you're a head of an organization, you've got to bring educational stuff to them. The latest stuff. If you're the head of the whole Latin American neurosurgeon organization. Now, would you like data centers from all around the world, like one here, one there? You don't want them all
At this
clumped
one,
together, right?
no, at this point, anything outside my center is welcome.
Okay.
Yeah. So,
And in short, they assemble data sets of information that
yeah.
you want to use.
I've heard that, it's not the case for us, but people that are starting to do like startup companies onto this, they put it out there and they make it contingent on you are going to get some revenue if we're successful with this. You're an
Okay.
institution, and so they do agreements for hospitals to get a certain percentage if the startup comes, but we're not there.
Okay.
And it's just me and a bunch of students, so at this point, but nonetheless, I think it's a very interesting model to have it in that way. So you get rewarded if you put the data together, and then if the company is successful, hey, good for everybody involved.
Yeah, of course. Yeah. Yeah.
But in terms of the scientific aspect, I think we need like people like the National Institute of Health or Radiologists Society of North America to make these challenges where all the centers pull in the data and they label it. They have now they done that for lung nodules, or they create like these huge data sets for scientists to use it. And unfortunately, in neurosurgery, this is not matched yet. Though for the intracranial hemorrhage, there was one. Radiology Society of North America has put over 63,000 cases together.
Well, you may have heard this story, but in China, in Beijing, they have a shortage of radiologists, so they have AI read a lot of chest X-rays, a lot of chest X-rays, AI, and they bring the ones in question to the radiologist. But a lot of X-ray, because I interviewed the head of this company from China. I'll try to find it. Try to find a video interview of him using AI for chest X-rays in Beijing. I mean, they have so much pollution there. They have big problems with lung problems. Hello, Takashi.
Good evening.
How you doing? This is Cyprian. I think you met. I don't know if you met Takashi from Japan.
We talked, before.
Yeah.
So.
Okay, Cyprian. Before I forget, I know 3 is plenty for you to do webcast, and I appreciate it. Anyone else that I would like to get some names from other places that I can approach, because I like to keep the topic going, and like to keep. So anyone you can think of that would be significant of adding to the knowledge of AI and neurosurgery, just let me know, and I'm going to ask them to interview too. So
yeah, absolutely. I know quite a few folks. As a matter of fact, most of the scientists right now, if they didn't jump into the AI aspect for imaging,
well, it's more neurosurgery, any neurosurgical, if you know of that aspect of it. I know there's tons of AI, which I really don't want to get into. I want to kind of limit it to neurosurgery.
All our neurosurgeons, they're into AI. Dr. Jason Davis and Kenneth Snyder, all these folks that are working at the.
Yeah, we'd love to talk to them if they want. I'd love to talk to them.
I'll ask them. always the problem
This
with us
platform is yours to use.
is
This is a great platform, man. It's great.
so they're always because we're a comprehensive center, stroke center. They're always on call. Like it's they're so busy all the time. But as far as I know, they do broadcasts for conferences and even live cases.
Yeah, yeah. I mean, it's a hot
Because
topic now. Strokes, man, a hot topic. Hot topic.
and among other things, it is an issue about opening more and more to endovascular approach with these guys from they're trying to do tumor treatment based on photodynamic therapy and the release of the drug via catheters. So I see a lot of them trying to get into this, but the question is again, are you done? When are you done? Is this image? What does this image that you acquire means? So
Sorry, I was distracted here. Okay. Yeah. We're exploding too. So we're going to start a Russian channel because a lot of these countries think that it's limited to English, the broadcast, but there are some countries. It's like international language, English in neurosurgery. Yeah, but a lot of neurosurgeons that live in other countries, they don't know English well, and they'd rather hear their own language. So I know in Latin America, I was surprised to find out that a lot would prefer in Spanish. So we do a lot in Spanish there.
I've seen your announcements sometimes in Spanish and stuff. So
yeah, they're a good community. They like the technology, and the bandwidth's getting better. I've been doing this for a few years, so I can see how the bandwidth is getting better gradually in places like Latin America and India and Africa. Not tremendously in Africa or India, but it's getting better for sure. Generally.
Yeah.
So
I am looking still for some of these applications to move into things like open skull surgeries and so. But for that, we need this to get into on the microscopes and get some of that data to us. So it looks like I have only 1 minute left. Should I share my screen, or you?
No. Let me introduce you first. Yeah, let's just wait a minute. I said it'd be here. Let me text him again. I'm just waiting to hear from Hype.
So I experienced two like problems yesterday on Zooms. Usually doesn't happen. I have like a very good connection. In case that happens again, I'll be right back. So
yeah. Okay. Yeah. We have webcasts with Atul Goel in India. He uses a Wi-Fi connection. I don't know how it works reliably, but it'll occasionally just go boom. But we know we'll have 80 people in the panel waiting for him to come back.
Yeah, so it's going to, I don't know, yesterday it happened twice, so might happen again.
Yeah, it's weird. Zoom's been acting a little strange. Not much, but definitely. Oh, Ben's here. Oh my God.
Okay.
Yeah. Great. Another home run.
Hello,
Hey,
John.
Ben.
Hello.
Ben, how you doing?
Hello, Cyprian.
Hello.
Hey,
Hi, Ben.
Ben, can I put you to work?
Uh-huh.
You want to moderate? You want to moderate and introduce the speaker and say a few words when we start? Just host. Do you want to host? You want to host?
I'm trying. No.
He put you. He put you on the spot.
Yeah, we put you on at the last minute.
Yeah.
Okay.
Actually, I transferred my email to another mailbox. Then I logged in because the former email you sent me is in my cell phone. So now I'm using the my desktop.
Okay, you want to give Cyprian your email?
Okay. I think. All right. So I'm ready when you're ready, John.
Okay, very good. We're all set. Okay, 10, 9, 8, 7, 6. Wrong screen there. Hold on. I got to get off the spotlight. Let me get ready. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We have part 3 of a series of webcasts done by Cyprian Ionita, a PhD from University of Buffalo, Jacobs Med. He's going to be talking about generally the interface between artificial intelligence and neurosurgery, an exciting topic nowadays. So welcome, Cyprian, and thank you.
Thank you for the introduction, John. So let me share my screen here. Right. Just a second. Now this one, share. Okay. Can you?
Yes, we can see it.
Can you see this?
Yes, perfect.
So it's just a full slide, real-time surgical guidance using AI?
Yes, full slide.
Thank you. Okay, thank you. So today it's the third part and the final of use of AI for neurovascular interventions. And I started with the predictions or triaging of the patients, then with the complications. And today I'm going to kind of like go over potential use of the AI by the endovascular surgery. Again, my conflicts of interest are here. I have some NIH and NSF funds, and I have some patents relevant to this presentations. So the AI medical applications, as we said, then at least into the endovascular procedures, we start first with simple things to help triaging patients and to help with stroke diagnosis, especially in the areas where there are a lot of patients or they have a lot of cases. And this in general is just for early identification of the patients and really for patients to identify those patients that are immediate risk and prioritize them. The next thing that we have talked about it is to detect complications during the procedures. With many cases and subtle changes into the flow, into the angiograms or images, there might be a chance sometimes that complications or small adverse events not to be noticed, and we think that AI in this case may enhance the neurosurgeon's practice or procedure by identifying these potential complications and flagging them. Again, this is not something that, let's say, the AI will fly solo and will take over as a procedure. It's just to bring to the attention of the interventionalist or as a neurosurgeon that something might be wrong into a certain area. And today, I'm just going to go over treatment planning and treatment guidance using the AI predictions. So again, this is a repeat of a few slides, or a repeat of the previous one of my previous lecture, part 2. I wasn't sure how many people have seen it, so I'll just quickly go over some of this. So the procedures that I'm focusing on are exclusively catheter-based procedures using X-ray image guidance, where the neurosurgeons takes the catheter under X-ray guidance, takes it to the area or a lesion is located into the brain, and using different devices usually tries to modify the flow into the lesion, or reestablish flow, reduce flow, etc. So why do we want to do this? Well, it minimizes in general the trauma, the pain, the blood loss, and reduced wound complication. Is not very uncommon to see a patient released within 48 hours from the time of acceptance for some of these elective procedures. So bottom line, it is added safety to the procedures. Well, the issue with this is that some of the procedures that we do, the devices that we use are limited. We do not have ways to measure directly the effect of the treatment that we're doing. And a lot of these procedures may require additional or follow-ups. It's not uncommon for aneurysm treated with coils to see 2 to 3 follow-ups where coils are being added, or due to incomplete occlusion, etc., or coil compaction. So I'm not sure how many in my audience, how many were trainees or residents. So, and I will go over this a little bit because they are the main focus of the presentation. For aneurysm treated with coils, a device like this is placed into the aneurysm, and the idea in here it is to use the structure of the device to reduce the risk of rupture by modifying the hemodynamics into the aneurysm dome. The need for this one is to have a narrow neck in general, not to have the neck is actually in here is the most important part to decide whether to treat or not. The other treatment, it is a simulation or simulating the concept of the flow diverter. This is not a flow diverter, but the idea, it is represented in here, that you divide a much denser device over here that will divert the flow away from the aneurysm neck. And there's different sizes. And if you're thinking about how the device works, it's like more like a finger trap. If you elongate it, the spaces in between the wire becomes wider, and the flow is less. And then if you're compacting it and bring it together, then the spaces in between the devices, the struts, the metal struts, become smaller and diverts the flow a lot. So there are neurosurgeons that are looking at this. And if the device, let's say you have a 3.5 millimeter device, they might oversize this or undersizing it. If you oversizing, and let's say for a 3.5 millimeter, you go over to the 3.75 device, you elongate it, and the pores in between become larger, so the flow into the aneurysm is less. If you go with a 3 millimeter device for a 3.5 millimeter diameter in here, then you have to crunch it together, kind of push into the device. And what's going to happen, you're going to have a higher density in here of metal over the aneurysm neck and divert more. The issue with undersizing and crunching it together, if you're not careful when you push onto the device, you will end buckling it into the aneurysm neck. So it requires a lot of finesse onto the neurosurgeons to kind of like feel the pressures into the catheters and the backflow onto the to avoid this kind of complications. So others, they want to be safer, and they're saying, I don't want to, let's say, really fully occlude this device. I just want to make sure it's not going to grow. They oversize. In other words, they are taking a stent that is slightly larger than the device, and it's safer for them to deploy without worrying about the device buckling into the aneurysm neck. So once this procedure is done, the only way that we can look at these devices and figure out that something is happening, it is using digital subtraction angiography. And we can look and measure all sort of things in here. stenosis, percent, intracranial aneurysm, so dome sizes, aneurysm neck, etc., to decide on the device that we can use, but not as much function. So here I'm showing you an example of an angiogram run. Here is a device, it is an aneurysm, and it was treated with that device, with a pipeline. These are the pre and these are the post treatment pictures. In general, the surgeon is looking at them and qualitatively is saying that I think I'm done. There is not much I can do in here. If decides that it's not done, some of them, like Dr. Siddiqui, sometimes places a microcatheter into this aneurysm dome over the pipeline before deployment and decides to drop a coil in, or decides to put a second coil in, or is wondering about it. You know what? I think this device, it doesn't have quite well the wall opposition, and goes with a balloon and inflates it slightly to make sure that the pipeline device is fully has fully oppositioned with the aneurysm neck. And based on these images, they have to decide. And as you can see in here, at 6 months follow-up, this is gone. So what kind, the idea it is, what kind of the flow information we can extract from these angiograms in order to decide whether we're done or you should do something more about this treatment. And this is more so about coiling, because coils, you can deploy them in one at a time and decide whether you're done or not. And the idea is that if you're really deploy too many, or you're pushing too much, you might rupture the aneurysm, or you might end with a coil coming into the main artery, and then you might have to deploy a stent assisted coil embolization that will put the patient again onto the antiplatelet therapies. So there is a lot of implications with regard to that deployments. So what we want to do, it is shown in here. I showed this picture with the bottom part where we're deciding ischemia. In here, we actually want to do actually real treatment. And what I'm going to go today, I'm going to go through this upper branch in here. So normally you treat, you wait 6 months, and you see if the aneurysm occluded or not, and then you decide again to retreat. What we want to do, we want to deploy a software residing on the C-arm that looks at these angiograms, and then without any user interface or any kind of application from the user, finds the aneurysm right there. It goes, looks where the aneurysm is located, and then I think we have a little bit of a background, John. All right, thanks.
I got it.
Okay, so and then not only finds where it is, it segments it out, which means takes only the area of the aneurysm and extracts those parameters out, and then it makes a prediction. And today my talk, it is about how we do this pretty much with AI, but I also want to show you evidence that all this data is supported. You cannot go to the AI and expect for it to do its magic and do a prediction that doesn't match our gut feeling, or not necessarily gut feeling, but our understanding, scientific understanding of the processes associated with this disease, with a particular disease. So the other thing that I'm going to insist at the end is that never ever use the AI to tell a surgeon that a definite answer and say, this is going to occlude. No, just give likelihoods of things to occur. Because let's say if the AI decides with 52% that this aneurysm is going to occlude, is going to give a definitive answer. Then a 52% confidence into a prediction, it is not the same with a 90% confidence. So it is good for us to break the AI down and show the surgeons how confident is the software into that, and display it into our interpretation or predictions of the data. So let's go over the physics of it. So as I said, in the aneurysm, what we are trying to do, it is to use the contrast to decide whether we're done or not. And in here, I'm just showing you some data, scientific experimental data, flow data that backs that up. So we took phantoms like this you see in here a long time ago. We've been at this for more than 20 years. I would say that the flow diverter concept also emerged partially also in Buffalo um, uh, in the early 2000s. So the device is placed across the aneurysm neck and diverts the flow. Here you see an untreated one, and you can appreciate here 314 millimeters per second, about 31 centimeters per second inflow impinging into the aneurysm neck. And then we use different flow diverters. Again, we can modify by how much it changes the flow in. And here is one that reduces to 5 millimeters per second, and another one that reduces to about 2.9 millimeters per second. Also, the vorticity inside dropped from 100 seconds to -1 to 1 second to -1 and so forth, 2 order of magnitudes. And now when we look at the X-rays, you see these are the velocities. And how do we know that this is right? It is because we measure them, and this is kind of showed the concept. We pass these particles through those phantoms that I showed you with a laser. We shine the laser, and we track small particles all around. All these particles are being tracked, and then gives us measurements like this. So we know exactly the flow, how it goes in. And when we look at the contrast, how it goes in, it exactly follows to a certain degree. The flow is from down up. You see the vortex, and then it goes from here. And as again, you see like it comes at the neck, goes out, comes as the neck and goes out, not quite like here. And here you see it goes right at the neck in, sips in and goes out, exactly the same. So the key point that I want to make is that yes, the contrast follows the hemodynamics up to a certain degree. So we have to go, and when we look at the contrast flow, we can trust it. We can trust that the patterns that we are actually see are related to the hemodynamics and the hemodynamics changes that come into the flow. The problem it is, if I'm asking a person or a surgeon right now and tell them, is this going to occlude or this one is going to occlude? Because this is not available. These velocities, forget it. They are not going to be able to for us to measure them into the aneurysm when we use the devices, because there is a bone in the way. We cannot use ultrasounds. We cannot have any means to measure this kind of velocities. And this is where the bottleneck or the problem is. If we would measure these velocities, we don't need AI any longer. But the situation is in such a way that we can't, and the only way we can look at these processes, it is through the digital subtraction angiography. So how we do that, I told you before, I'm just going to go really briefly. We look at things like dye dilution curves, and as the contrast propagates through the system, they tend to spread really, and this is exaggerated. They are, the differences are slighter. I would say something maybe between and this and that occurs, but we can look at these parameters and figure out what are the, and infer kind of like estimate what hemodynamics are going in there. And we measure these quantities, which are very common for the people that do CT perfusion to evaluate stroke: mean transit time, time to peak, peak height, etc. Mathematical formulas are given here. We use, we're kind of old school in this one. We're using the gamma variate functions. A lot of the in the CT perfusion now, the more advanced techniques like CT, like SVD plus and Bayesian algorithms are used to evaluate those flows. And it just goes exactly like in CT. You take the data, you look, you do some processing to make it faster. You look at every single voxel, in this case pixel, derive this kind of curves, you speed it up, do the analytical function feeding, and derive the parameters, and then do this for every single one into the image, and you get pictures like this. So again, these pictures are as you're looking at the flow with different filters, and every single filter gives you a different kind of information. For the mean transit time, for example, is the average time a particle spends into a certain area. Time to arrival, it is how fast it got there. Peak height is almost like cerebral blood volume. And for the artery equivalent, how much contrast gets into a certain area in this case. So an area under the curve, it is a combination of the mean transit time and peak height. So the question is, are these parameters related to the hemodynamics? I show you that the patterns are, but the values are. The question is, are they related? And here we did again lots of experiments where we really confirmed that mean transit time, bolus arrival time are related with the velocities, because we have pumps that can control this. We have ultrasound. We can go into that our region of interest area, measure it. This is all benchtop kind of experiments, and we know that it goes. And look at this for different flow rates in milliliters per minute or in centimeters per second measured at that area. We see that there is direct correlation between bolus arrival time and mean transit time in there. And these are very repeatable. So what is the problem? Why we cannot have just a mean transit time at some point really tell us what's going on? You take the mean transit time correlated with the disease, with the outcome, and things will go easy for you. The problem is this. Nobody is going to inject with an automatic injector and in the same center. And across different centers, it is even more different. And if you look at, let's say I have in here an automated injector and I did do 5 milliliters volume, and I do a 10 milliliters per second. I'm sorry, a different injection rates, 5, 10, 15, and 20 milliliters per second. And we're looking at this situation in here, at this aneurysm. What are the mean transit times? And there is a huge variation in here. Because now, if I have a center and say, hey, this surgeon in here is injecting 20 milliliters per second at a 10 milliliters volume, and another one somewhere else is injecting something less at 5 milliliters, and so they're going to get the same mean transit times. And here, what we did, we place a stenosis. And then he's going to conclude that the patient with a stenosis has the same kind of hemodynamics as a patient without stenosis, which is entirely different kind of hemodynamics in there. Again, injection parameters or the hand injection, it is extremely important, and it will skew the data to the point that you cannot relate an angiogram from one center to another. Hence, we need to take care of this. And we have developed something that is called an SVD, which is single value decomposition correction, where you have to go for the ICA. You take really the arterial input function like you do it in CT perfusion, and you fix for it. And not only that, we flatten it and we say, this process, what it does, it is simulating or bringing the data as if you do a hand injection with a delta function. That's what it is, which means a very short injection with and a lot of contrast, and as if everything happens in a fraction of a second. So it brings variability to that type of injection, simulated injection and the parameters. And what I want to point out is that stenosis versus, in this case, versus non-stenosis, a big difference in between them. And it's independent on the milliliters per second. And in the same way, it's independent of the volume. The volumes are they are overlapped. Again, this is stenosis versus non-stenosis. Now, with a mathematical process like this, we can start seeing we reduce this variability that doesn't make any sense. We want to just take hemodynamics of the lesion, and in the same time takes away some of the corrections. And I will show you why I'm going through this, because it's extremely important. It adds a variability which limits our ability to predict what's going on. And then if we add the C-arm changes into the play, then it's going to be even a bigger problem. And when we have these variabilities or these inconsistencies in the acquisition, we are not able to do our job properly. So what we're going to do, we are going to go back. We're going to start looking into things like AI or data-driven models to help us overcome this variability and patient variability by looking at lots and lots of data in order to solve the problem. So the current status that I will show you today of our AI technology is as follows. It detects the lesion, in this case the aneurysm. It goes and extracts the parameters. Then it predicts outcomes. And again, here I have to make sure that I make myself clear. This is not outcomes like yes or no. We were thinking as engineers when we started this, and we like. Can you stop that?
Почему?
I'm sorry, I'll get that. I'm sorry.
Ну,
Okay.
можно же вниз.
Okay.
Thank you.
Okay, that's
Thank you.
fine.
And again, it's not about prediction of the outcomes. It is actually likelihood. When we started in the beginning, where as engineers, we wanted to predict everything and tell everyone that this is the ground truth and so far. And as we talk to more and more of you guys, we realize that we have to step back and step back and step back and actually behave like physicians, give you likelihoods and so far. And then also the protect against complications. Let's say a wire might go through the aneurysm neck and creates a subarachnoid hemorrhage, and predictor, let's say, of something like a delayed cerebral ischemia. So first of all, how we tackle the aneurysm identification, or how do you do for lesion identification? And this you can apply again for any kind of lesions. You can do for AVMs, you can do for intracranial disease, stenosis, and hemorrhages. So we took 350 DSAs, and again, this is our limitations. We're working on one center. It is only Canon. It's Canon equipment at Buffalo Gates Vascular Institute centers. We use only adult patients treated for sacral aneurysm with coil or pipeline, and and we're using, as I said, Canon Infinix biplanes for everything that we do. If you're wondering about the distribution, 55 prior for treatment, 45 following coil procedures or pipelines, and these are the distributions. We went really from mostly in the internal carotid, and we're very limited, like in our studies on the basilar and posterior cerebral circulations. We also use 45 true negatives. So poor image quality, it is a big problem. Things like this immediately throws the AI off. Even an aneurysm like this, if you're not careful, the AI might be actually be thrown away. So one other things that AI could be used in these cases, it is actually fixed for this kind of artifacts. And then what we did, actually, we processed every single sequence to increase the signal of the aneurysms neck. And then we had the neurosurgeons or fellows, not the actual attendings, fellows and residents and scientists go through every single one and hand contour the aneurysm. We can have an automatic feature that can segment all the arteries in here, but for lesion itself, it is very good if you have somebody go and hand contours it in order to make sure that that the data is right, and it better be an expert in the area. And now, as I said, since we are one center, this kind of data is not quite good for us for the training of the AI, and we need into the thousands, and that's where collaborations come very, very important into this. I would say if you want to do an AI that is relevant to many centers and many a large population segment, you need collaborations with different centers. So in order to bypass this, we really did, we cheated in a way, and we did rotations, we did zooms, we did a little bit of data augmentation, what is called, by messing up or changing the images. And we made sure that when we crop, the aneurysm is not out, like in this case, so it becomes a true negative in this case. And then we we got 1,500 examples, and 600 we kept for testing. In other words, these guys in here you never touch during the training of the network. For those interested into the details of the AI structure, we use Keras, and we use what is called a VGG16 architecture. And this one was developed really for detecting or type of objects onto the internet pictures, labeling pictures onto the internet. And what we do, we kind of like look, you train the networks, and as they are being trained, this parameters that you see in here in convolution 1, 2, 2, and so far, all these segments are the weights or the experience of the AI is being set. In other words, we're going to go and we take those pre-trained weights on existing data that is out there on the internet, and we start with those and apply them to our images. That saves us a lot of time in order to do things like segmentations and so. This is about 3 years old, I think, no, 2 years old. And it was awarded at the SPIE Medical Imaging in 2019. It received an award. So since then, we improved this method. Again, for people that are interested into details, this is what we used at that time. We use an ADA delta, zeta depth learning rate over time. We did transfer learning, as I said, from ImageNet, and in order to calculate this, we use to calculate the efficiency or the accuracy. Use what is called this dice to optimize. I'm sorry, we use a dice loss. For quantitative analysis, we're using the normal area under the curve, but also Jacquard index. And how do you read this for those people that are not familiar with it? It is, you have two shapes. In this case, this green stuff, this green square, it is what, let's say, the expert labeler has done. And the red one, it is what the AI comes up with. If you get something like a 0.4, it is a poor match between what AI predicts and what the labeler has done. This is a good agreement. An excellent agreement is usually you're looking somewhere into 0.92. For clinical applications, you must be somewhere in this area and above in order to do the segmentation. This is another coefficient that we have used. And we used also this network next to determine where is able to extract those parameters, those flows parameters, those angiographic parametric imaging parameters, to see if it is able to extract them. And we compare them again with some with a expert user. We had, for every single case, we had an expert go and extract the parameters like mean transit time, time to peak, and we compared the AI with this expert user to see how it does using Pearson correlation coefficients. Here are some examples of the results in here. You see, we start with an image like this, we have a sequence of data like this. These are hand contours, and you see the user usually places a circular ROI, and he places also one here to take into account those variabilities because of the hand injection. And as you see, this is done. We don't need this to be done with AI. We can do this automatically just by image analysis. So I will focus only onto the aneurysms. And you see here how the AI has done a pretty good job at the aneurysm, but the distal part onto the arteries, it's so-so. So in general, it's good agreement between this. And if we use coils, again, there is no problem. Very good agreement between what a user will do and what the AI will segment. I would say the AI actually is better because it doesn't do this kind of circular placement. It goes and identifies the edges. And the thing, it is slight motion artifact, it is okay. It is not being thrown away. If the patient has, in this case, this patient had a intracranial hemorrhage and he had a craniotomy, as you see in here, to in a shunt placed. Again, no problem when you have hardware like this in here. Highly attenuated structure is not throwing it off. because it has been trained only to look at this kind of data and can easily ignore those. Other things like you see again another example of a stent assisted aneurysm. The stent, you cannot quite see it well in there. Catheter presence, no problem. It can ignore it very well. Area under the curve for aneurysm neck detection or the aneurysm sac detection is 0.798. When you look at the Jacquard indexes, it is into the area. Again, this is overlap, dissimilarity coefficients, area under the curves. They're into the clinical area acceptable, and confidence interval pretty tight nonetheless. For vasculature, in here, it is on the bottom. What we're focusing in general, it is over this values, dissimilar coefficient, similarity coefficient, which is really good. We like it. However, again, for the area under the curve for the vessels, it is a problem because it's trying to segment this low signal data in here, and it's poorly enhanced. So, but again, we do not care when we look for lesions. We do not care about this artery in there. So the peripheral vascular, which is very small, is not a problem that really does not segment it very well. I care about what is here, and in the area where the aneurysm it's segmented, it does very well. Now the question is, how does the AI does in extracting those parameters? Bolus arrival time, time to peak, mean transit time, area under the curve, peak height, and the error, it is 0.2% between the AI and the human. All right, so correlation, again, superb. It's Pearson coefficients almost, except for bolus arrival time, it is pretty good. It's a very strong association with the API values. Now the thing it is, let's say what we're saying in here, it is that the AI performs non-inferiorly to an expert user in taking these parameters. However, unlike manual input where you have to load the data, look through them, do that, which can take anywhere for somebody that is not quite an expert, can do 20 minutes to extract and save that data. At the time when this was done, it was 5 seconds. Right now, it is 0.5 seconds in extracting the data by this AI, which means it happens almost instantaneously. After every single angiogram, this software or this approach, this AI approach, can go and extract these things. And really, what does this open for us? It is to be used in the clinical setting, extract those parameters, and actually perform some sort of prediction of the outcomes or the prognosis of the outcome. And right there in the angio room, instead of waiting at the 6-month follow-up, to allow the surgeons to do the adjustments. So here are some situations: case A, case B, case 3, all treated with coils. And what we see the cases before, and then we see what's happening after. And when we ask them, well, is this going to occlude or not? And the idea is that at the end of the day, you see in here, one of them is totally gone. One of them is partially. And this one, it's pretty much there. Not only that you have the neck and regrowth, but you have also into the dome. The same thing applies for the flow diverters. Here is the aneurysm. Here is a flow diverter. You kind of like see it in there, depending on the screen on your the resolution on your screens, and then the aneurysm is gone at follow-up. Case B, 5 aneurysms on this patient, 1 big pipeline that went from there all the way down, blocking every single one. All of these guys gone. This one in there, depending if you look very careful, it is some sort of a seepage in there. But in this guy in here, here is the aneurysm. Here is the after the treatment. 6 months later, nothing happened. So the question is, can we tell them at the treatment whether they're the surgeon, or what is the likelihood? So to allow of occlusion, so the surgeon can do an adjustment of the treatment. or at least put that patient on observation, because something like this, you might end with it rupturing. So the way we are doing it is we are taking these parameters, and we're taking parameter before and after the treatment. We always do a baseline comparison. And then we are looking at this 4 maps: time to peak, mean transit time, peak height, and area under the curve. We have done this over a few hundred cases to train our networks. The first module of the API, or the AI, takes the data, passes through a deep neural networks, makes the prediction, and then here it says with an 81 probability that this aneurysm is going to occlude. And in this case in here, it said with a 99.8 probability or confidence, this aneurysm is not going to occlude. And indeed, when we looked at the 6 months follow-up, the aneurysm was there intact. So what you need to know is that you need to address this, and this is where we spend a lot of the time. 2 to 4 years we spend on how we make sure we account for everything. So because into the AI, junk in, junk out is going to be if you're not and this is where is our proprietary method. And you have to kind of like figure make sure that look what is happening as the prediction of or the accuracy. If you use raw data without any processing, without accounting for hand injection, without accounting for C-arm orientation, and so you're getting a flip of a coin, worse than a flip of a coin. Now, when you correct for injection, you get into 0.67 area under the curve. When you do also account for C-arm orientation and for shortening, you get into the 0.77 area under the curve. And our interface, as it is, the one that we have developed right now, what it does is still manual. We hope this will be on a C-arm. It just goes, loads the data, then automatically, without the surgeon interfering, finds the aneurysm, extracts the arterial input function, and then it predicts what's coming on. And it gives in here, right there, displays the maps, says probability of unsuccessful treatment in this case is going to be 79.9%. It gives you how the values, tries to do some interpretation and say, hey, before the treatment, you had a mean transit time of 1.08. After, you have a 1.04. Your mean transit time went down for the area where the particles went in. That should be immediately a sign for you that particles spent less time into the aneurysm zone than before, even though the peak went from, let's say, from a 0.819 to a 0.78. So the peak has decreased by 10%. You see less contrast goes in, it gets out faster. And the signal should be, hey, this has a problem with wall opposition or some, so the way I diverted the flow needs to be reassessed. I will end with where are we going next with this? And we want to add even more physics into it. So you remember that I said that the AI just tries to find this function that takes the input to the output by comparing it with a graph label, and is just comparing them over many iterations until you get you show apples and it says it's apples. But now in here, we're thinking to go one step farther. And it says, hey, for this kind of flow, add some physics into it. Let's put in there things like mass conservation, conservation of momentum, conservation of energy into those decisions when we optimize this. And it's, do not worry about the equation, it's just examples, doesn't mean absolutely nothing. But we can take stuff like this and say, these are the rules that in this gray area must be followed. These are the rules that the physics or the contrast that you see must follow. And we take that and we make like a loss function. It's what we minimize, the error that we try to minimize. And then we tell them again, boundary condition. Outside the gray area, everything is 0 on these areas. And when it comes in here, you have to have these velocities. You kind of like go and you add every single physics phenomena that you have into this huge term in here, and then you put it to go to 0. So when you train the AI, you tell the AI, hey, minimize this function instead of minimizing the error between the values that you have and the things and the expert users. And the thing it is, it doesn't matter what you're doing, because even with the simplest of the AI, you always calculate these values. You always calculate derivatives in order to minimize your function. And here, what you see, it's almost like a real-time predictions of, in this case, the velocity into this direction, velocity V is into the Y direction, and the pressures. And imagine until now, these are simulations, by the way, but imagine until now, in order to extract this kind of velocities, what you did, you put into something called computational fluid dynamics, which can take 48 hours to calculate. What about having something like this? As soon as you upload from your data into the surgery, you upload a picture like this, it starts calculating those values and tells you what is happening. So we're moving even one step further when we can do physics inform artificial intelligence. So I'm going to end this. This is a big back to the big picture. We are into this domain. We're looking at stroke protocols to triage the patients. We're looking at actually detecting in real time if complication has happened, and we're trying to predict as well if a surgery is going to be successful. This is, in a way, the big pictures in here. In order schematics, there's 2 AI units residing on the C-arm. One of them is looking at identifying the lesion and predicting occlusion. The other one tries to detect area of delayed ischemia or acute ischemia, telling the surgeons that something is going on. And we want to do this without any kind of disturbance into your workflow. The idea is this has to be as stealth as possible. We need to work with Canons and Siemens and Philips and GEs, and I'm sorry if I forgot any of those others. We need to have this software working on their C-arm to actually help you in real time. Without them, forget it. This has absolutely doesn't have a value, because you're not going to step out of the surgery room, really look at a software on a laptop and go back in. It is just not going to work. So with that in mind, these are my collaborators. Every single idea that we presented that in here, it is done by the engineers, but it has been initiated by this gentleman. Dr. Siddiqui, Dr. Levy, who's the chairman of the neurosurgery, Dr. Ken Snyder, and Jason Davis. These are their patients, and they come with the problems to us, and then we try to solve. And these are actually the folks that write the code. They go stay in the M&M meetings, they go to endovascular planning meetings and discuss, just listen to the neurosurgeons teaching their fellows and the residents, and then they go back and write those codes that I've shown you today. With that, I think this is where I end the discussion, and thank you, John, for allowing me to give these 3 presentations over the last 3 weeks.
Yeah, thank you very much, Cyprian. And it's great to see those engineers interacting with neurosurgeons to make the project go forward. Okay, we're open for questions or comments.
So Cyprian, thank you for your nice presentation, and it's really fascinating. But you know, the aneurysm rupture rate is correlate with energy loss according to the Bernoulli's principle. So can you calculate the energy loss when you do the angiogram in the spatial segment of the
to calculate what loss?
Energy loss.
Energy loss?
Yeah, like the dynamic energy.
Yeah.
Yeah.
So
because you know the local energy loss may be the cause of the rupture of the aneurysm.
As this is the work of my colleague, Dr. Hui Mong. He has put a lot of time into this, and she's calculating these risk rupture scores. And that's something they're looking into it. And they also went to the AI because to account for huge variability into the data sets that they are seeing. Until now, a lot of the computational fluid dynamics have relied on idealized boundary conditions, those conditions that I said what's happening at the input and the output, which is not the case. Every patient is different. Every patient has different input hemodynamics conditions, and they are looking to use this AI to improve their CFD. And since it is about aneurysm rupture prediction, it is not really imminent to happen in real time.
Yeah.
We can take a CTA, preferably cone beam CT on an angiogram, and then use that. And that's like really, really very hot topic for them. Use the AI to extract boundary conditions so we can make our CFD better.
Yes, thank you.
So you just nailed it right there.
Yeah.
We spend a lot of time into that.
Yeah, just as you mentioned, the idea stent should be partially high density meter rate to cover the neck of the aneurysm.
Yes, would be. Hopefully, somebody from Medtronic will see this and listen to what you have.
Yeah.
Oh.
Okay, thank you.
Okay, thank you, Ben. We have a question from Mohammed Helmi, a neurosurgeon from Egypt. Greetings from Egypt, exciting lecture by Professor A.E.I. Unita. I wonder why didn't you apply this technology more to the posterior circulation aneurysms? As you know, the post-circulation aneurysms are less debated to undergo coiling versus clipping.
Yeah, so first, the pipelines that we really focused a lot because it looks like that the field is going to that direction. They're mostly into anterior circulation. Now, every now and then, if you go for a pipeline into, let's say, into the basilar artery, it is like asking for trouble because of all those perforators in there. As far as concerned coiling into the posterior circulation, we are actually doing that. Some of those results for segmentations are for posterior circulation, and so. But as I said, we really use one single center, and we see that whenever we're wrong, it is very likely to be wrong about posterior circulation. So more data into posterior circulation in collaboration with others to make sure that we have a uniform data set will be really awesome. We don't have just enough in our center enough for posterior circulation. So and I'm not answering your answer really, but we do not spend that much time because we really don't have that much data into that space also. So anyone that wants to work onto this, we are more than open to.
Yeah, so you're looking for data centers, correct? To supply that data. So,
In collaborations, and I understand that everyone is tied by these IRBs and the rules, which are really draconic everywhere. And I have like really no easy solution other than have bigger organization like National Institutes of Health putting out these challenges where different centers can contribute to create these data sets or so, or otherwise having just us collaborating is going to take a much longer time. They can snap their fingers and all of a sudden 60 to 100,000 cases materializes, like RSNA does it all the time. In the neurosurgery, we don't have that.
Okay, we'll work on that. Okay, more comments or questions from the panelists?
Yes, I think the aneurysm rupture prediction is a very hard work because it's not only correlated with hemodynamic parameters, but also the surrounding structures like CSF, like the cortex, the nerve, the neurons, and everything surrounding the aneurysm dome.
Yeah,
it's
the wall imaging. It is like the really hot topic now. With the MRI, is looking at wall imaging and bringing that into the model. It's also very important for here.
Yeah, so you are also doing that work?
Yes, we are collecting wall imaging data for as much as we can right now.
Okay, great.
Very good. More comments or questions? Okay, great, Cyprian. I appreciate it. The time you took for the 3, and we'll have it edited and sent to you and be archived. And thank you, Ben, for coming. And Rosanna Romani, do you want to say hi from Argentina? I don't know if you want to say hi. Maybe I'm embarrassing you. I'm sorry. Okay, anyways, thanks everybody for coming, and we'll end this now.
Thank you.
See you later.
Thank you.
Bye. Thank you very
Okay,
much.
we just
Rosanna.
Oh, hi.
Hi.
John, I'm from Italy, not from
Oh, I'm
Argentina.
sorry. I'm sorry. I'm sorry.
Rosanna, now you're back to Italy?
No, I'm in London. No, I'm in England.
Okay.
No, not yet.
Okay.
Thank you very much for the presentation. Great. Nice to see you.
Nice to see you.
Bye.
Bye-bye.
Yeah, Blaine,
John.
man, I'm glad you came. I'm glad you came.
Okay, great. Thank you, Cyprian.
Thank you. Bye. John, I'll see you around.
Yeah, Cyprian, that was great. And any help you need, anybody you want us to contact, let us know. Please give me some names. Please give me some, just send the names. I'll do everything else, just the names and the contact, and that's it. And I'll do the rest.
Thanks. I guess next time we'll see, it's probably Sign conference, right, with Miri, and so.
Well, we put together the 3 in the playlist, it's called, and it's easy for people, easier to access it. And we're getting a lot of hits on the website. So I think this video will be seen and maybe can be shown to a lot of neurosurgeons over time, so that they get it. You know the problem. They don't have time to go to conferences on AI.
Forget it. It's you know, patients comes first, and the way we do a lot of times science is really walk with them. Sometimes we put the gowns on, or we put the scrubs on, and we go with them, and they discuss it while they watch the fellows doing it. And
well, you know what you're doing, having the engineers collaborate with the neurosurgeons. I mean, that is great. That is great. I think a lot of places don't do that. They develop things separately, and by the time it comes to the OR, you can't use it.
Yeah, no, that's a vision of Nick Hopkins, who created this whole thing. So he's also the mentor of Elad Levy, Adnan Siddiqui, and Ken Snyder. So he's
a neurosurgeon.
He was a neurosurgeon. He was one of the first ones to use catheters in neurospace.
Oh, okay. Nick Hopkins, I don't know the name, but I'm not a neurosurgeon.
Okay, I'll talk to you later.
Okay, thank you very much, Cyprian. I really appreciate it.
Bye.
Okay, bye-bye. And the rest of the panel, Adnan, how you doing? Haven't seen you for a while.
John, I'm fine. How are you?
Good. How you been? I haven't seen you. You come and go.
Yeah, but I was a little bit busy, but yes, I heard all 3 lectures of Dr. Cyprian. First 2 lectures on your YouTube channel.
Oh, good.
And now live.
Good. Oh,
and
good.
I wrote to him. His work is very, very impressive, innovative work. But still, we are lagging behind here in Pakistan. We have to do a lot of things to reach till that level.
Well, hopefully, we'll with technology, we'll be able to go ahead in the years, make up for years, with technology, with things like this. Hopefully,
Exactly,
like
hopefully.
Cyprian said, he needs to establish some data centers. And you know what? There's no one in the world it's better to say that to than Ben. You saw Ben there, right?
Yeah, I have seen.
I mean, he's from the most populous country in the world that will have access to data sets. And they're the Chinese, they're tops in AI.
Yeah,
they're going to be the leaders in this. So we better pay attention to what's going on. And we like to well, we like to collaborate, obviously, for the benefit of both.
Exactly.
For brain surgery in China.
Ultimately, it will help out humanity. It will work for all.
Yeah. Chinese neurosurgeons know that. I don't think there's a problem there. They understand that. So I think they'll gladly collaborate.
Yeah, sure.
So I would guess. But yeah, I guess there's regulatory processes you have to go through. I wasn't familiar with. But Cyprian said briefly that it's a U.S. side of regulatory, not foreign. I'm hoping that it's a lot less stringent in China with the regulation of how AI is used. Because, you know, like the United States will say, if they assemble data, and it can't include the pictures and can't do this and can't do that. And some of them are ridiculous. You know, even for, imagine this, for an ankle x-ray, right? Which you don't know what person, you can't use it without the patient's permission. Now, how crazy is that? How crazy is that? How could you know someone's ankle bone?
Not identifiable.
Yeah, not identifiable. I mean, what are you talking? I mean, it's ridiculous, the laws. Ridiculous.
Ethical approval, that IRB boards and permissions, these are the hurdles to acquire that
education.
from
It
different
really,
sources.
there's got to be some, but I mean, it's overblown and needs to be updated for the digital age. So, anyways, okay, it's good to see you, and thanks everybody for coming. Thanks everybody for coming.
Thanks a lot for helping us.